Thank you very much. But here's another question I thought. Very often you'll hear the word, oh, maybe someday we'll find a cure for cancer. Well, I think you already probably should have figured out that that's by the way we understand cancer today. That's not possible. Okay, now there may be some types of malignancy specific where we could pin down specific mutations or proteins or processes, and perhaps learn how to regulate those better. But for the most part, if somebody tells you that if you drink a certain food or eat a certain vitamin, you're going to cure cancer. If you smoke pot, it's going to cure all diseases. That just can't happen. But I will say something that it's very possible also, in my hope and my dream, is that just maybe someday those of you who have heard some of the basic common explanations of the causes of cancer will just think about this. Think about DNA repair. Think about telomerase. Think about mutations, and maybe you'll just get fixated on something, and maybe you will. The lab that sponsors me, GoPath Lab, is very much into immunotherapy now. So think about it. If there is a oncogene which is results as an expression of some type of abnormal antigen on or in a cell. And now we could direct immune therapy against those antigens. In some cases, and in some types of cancers, and you'll see this in the literature, that cancer is so well regulated. I've even heard doctors use the C word for cure. And specifically, Jim Liu, the guy that pays my fees here for the webinar, has actually had a couple of patients, which on the basis of genetic testing has resulted in successive immunotherapy, where the so-called doctors have told him, make out your will we think that you're cured. So once again, I said it in the first webinar, and I'll say it again. My own wife had a very advanced severe cancer. But the two things that you'll hear from all the oncologists is, number one, we're moving towards a direction where maybe we can make it a chronic, controllable disease, like AIDS. Now, here's the other thing that you'll hear every oncologist, the most brilliant scientists in the world, the people that are just geniuses and working on all this stuff, they will tell you, your oncologist, well, all of your oncologists will tell you that the number one thing that determines cancer survival, your attitude, believe it or not. So I know we talked about a lot of genes and a lot of processes, but don't forget, we got a big process here which ultimately controls everything too. So let's finish our discussion. It won't be as grisly as the first half. And let's talk about tumor angiogenesis. Now, no tumor could ever be more than about 1 millimeter or 2 if it didn't have a blood supply. So you probably have to think that some tumors, on the basis of their malignant transformation, or even more likely their malignant progression, would secrete or make VEGF and FGFB. Remember, these are two of the big angiogenesis factors that we see in the part of the repair of damaged and inflammatory tissue, which we call angiogenesis or granulation or organization. And think about it. It's not just a case of a gene making a substance, making this, but it's really like everything else in the body, it's a balance, okay? It's a homeostatic balance. Everything in your body is properly vascularized because there is a good balance between all of the factors which promote angiogenesis and all of the factors which are anti-angiogenic. It's that balance. So tumors can disrupt that normal balance of angiogenesis, anti-angiogenesis, and tip it in the direction of angiogenesis. And many of the specific treatments for cancer are basically go for anti-angio. Some people want to infarct the blood vessels that go to tumors, okay? But even more than that, there are many, many mechanisms that would regulate angiogenesis. It's like there are many, many, many mechanisms that regulate growth in general. We've been talking about them all day. Here's another thing which we've talked about, but I want to show you what I think is the best diagram in the world. So I'm going to make this big again. And it's this whole spectrum now. Everything we've been talking about has been rather non-linear, different processes involved in the malignant transformation process. But now we're going to talk about something that's very linear. Well, how about if we start at one end of the line by saying that a cell is now a cancer cell. The cell can now grow. That's part 2 of the line. The cell can now evade or infiltrate beyond its normal mechanisms of limitation. In this case, it might be a basement membrane. Okay, type 4 collagen. Okay, do you think that maybe there might be some ability of these cells to secrete or produce collagenase? You betcha. Now it's beyond its normal limitation of the growth, and it goes into tissue beyond that. One of the things that may be not far from it, usually not more than a millimeter or two, are regular blood vessels or lymphatics. Now, these same invasive mechanisms that have chewed up that basement membrane now have to chew up the wall of a blood vessel, more likely a vein than an artery, maybe even more likely a lymphatic than a vein. Now these tumor emboli, these malignant growing tumor emboli, travel downstream. Okay, in the case of a vein, it's now traveling upstream or up towards the heart or certainly the lungs. Now it has to have a mechanism again to destroy the wall of the blood vessel again and go into a different area. And that's called metastasis, isn't it? Now think about it. All of these processes require, in a very linear fashion, this transformation, the growth, the bone marrow invasion, the ability to breach the wall of blood vessels, the ability to get inside of the bolus of blood, moving downstream, embolizing, then adhering to another part of the blood vessel, then extravasating, just like it already intravasated, now it's going to extravasation, and finally we have a distant metastasis. This is not a simple process. This is a multi-step process as well. Just like we talked about the malignant transformation as being a multi-step process, the proliferation or progression is also very much multi-step as well. So what has to happen when you got that clone of cells, which is now called malignant, and it's going to invade? And remember, invasion is the key word that separates malignant from benign tumors. Well, the cells, these so-called malignantly transformed cells, have to loosen up from each other. Normally, there's a whole wide variety of biochemicals called cellular adhesion molecules, different types of selectins and integrins and blah, blah, blah. Even immunoglobulins, which attach cells. These have to loosen up, okay? Because now we no longer have cells which can differentiate to make these or to process these or connect to these attachment molecules. Okay, now we have something that also has to not only detach from each other, but attach firmer to their connective tissue boundaries, which in the case of a basement membrane is type 4 collagen. Okay, so do you think there has to be a collagenase involved if it's going to be breaking through collagenase? Or wait a minute, how about this? Not only has to it break through collagenase, but it has to migrate. It has to have the ability to actually move, okay? There are mechanisms for this. Most of the compounds which result in tumor cell migration are autocrine, which means they're made by the cell and they act upon the cell as well. So here's the diagram of what we just said. We got some cells that in the early processes lose their intracellular attachments. They go by a wide variety of names, but remember, we're talking about a wide variety of theoretical cells. We now have something that has a more firm attachment to the type 4 collagen or basement membrane or whatever is the normal boundary of that group of cells. So as it loosed up between each other, it's getting firmer. Why is it getting firmer to its collagenous boundaries? Because it has to invade it. And it might invade it simply by the ability to produce collagenase. Okay, plasminogen activator is also involved in that. Don't ask me how. So that's a 4-step process of invasiveness: is detachment, attachment, degradation, which is now degrading its normal connective tissue boundaries, and then migration. Okay, this is a linear process. You have to have one before you have the other. Most of the malignant transformation things we've been talking about are not quite so linearized. We don't know very often what gene has to fail before another gene. Here's some metastatic genes, however, and I'm not going to go into their mechanisms because it's very complex, and I've tried to understand it, and there's a lot written about it, but if you generally want to know some genes which are involved in metastases, here's one called NM23. Don't ask me what these stand for. KA1 and KISS genes, KI and then a couple of big S's. And remember, the metastatic process, which we saw in this diagram here, is a multi-step process, just like the carcinogenesis or malignant transformation process is. Part of tumor progression is metastasis. There are a lot of chromosomal changes. We talked about mutations of genes, in many cases point mutations, but remember, a chromosomal mutation might be a translocation or an inversion, and in many malignancies we see cytogenetic changes, sometimes even visibly, not just through gene probes and everything, where one part of the chromosome crosses over to another part that shouldn't be there. The most common type of malignant type of chromosomal change seen in malignancies are translocations. Inversions are pretty common as well, where one part of the chromosome switches with another. Okay, most of the hematologic malignancies, like lymphomas and leukemias, you have predictable translocations and or inversions. Okay, now that we have better ways of studying it, we're also finding an increased number of chromosomal changes in the non-hematologic malignancies as well, cancers of other major organs. But this is where they're most. In fact, many of the difficult classifications of malignant hematologic neoplasms, like lymphomas and leukemias, are based on the type of translocation that we see. Here's something that's going to blow your mind. This is just a list of different types of predictable, known, common, and sometimes even almost universal translocations seen in various malignancies. The most widely studied is chronic myeloid leukemia, and its understanding of this translocation and the fusion gene that is produced because of this translocated material, a new type of gene that has massively increased the survival of this smoldering, low-grade malignant disease. Acute leukemias, you see certain predictable translocations. They'll give you the number, and they'll give you the segment, and then they'll give you the names of the two chromosomes, and they'll give you whether it's P or Q, which is the long or the short arm. And of course, it's more likely to be Q, because the longer the arm is, the more space you have for a translocation, don't you? And then the genes that are involved, and some of these are what you would call a fusion gene, which is like a hybrid gene. So when there has been a translocation or an inversion, the attachment site basically of two genes then forms a new gene, which, as you guess, could very, very predictively be an oncogene. So here we have our multi-step process. These are concepts which are commonly talked about. We talked about the fact that you have to have several oncogenes and several tumor suppressor genes. Okay, and some people have given these, lumped them into categories. And for example, the gatekeeper concept is that our oncogenes and tumor suppressor gene mutations are the gatekeepers, and the DNA repair genes are the caretakers. I don't know. I think it's hard to, for me at least, to understand why they should be divided like this, but they are. But then we have a variety of tumor progression factors, genes, mutations involved in not only angiogenesis, but heterogeneity as well. And by now you may have thought, well, if all cancers ultimately are from one cell, then why aren't all the cells the same? Because in the process of progressing, these cells change, they differentiate, they have formed more mutations. So a single cancer cell can result into various types of cells. They may look different, they may act different, they may have different antigens, and some may multiply and some may not multiply. And usually the fraction that multiply is just a relatively small fraction of all the different or heterogeneous types of cells originating from that single malignant cell. This is the concept that I want to really stress, though, because you have to understand that we always have thought of certain substances as causing cancer. You know, carcinogens cause cancer. We have a list of, I'm going to show you a list of about 20 or 30 known carcinogens, okay? But it's not just the carcinogen itself that causes cancer. You need two things. Think about it. You not only need to have a reason or a cause of the mutation, which is called an initiator, but you also have to have some type of promoting substance, which is not technically a carcinogen. So an initiator or a carcinogen may not promote the cells, and the factors which promote or make the cells grow or normally even make them multiply may not be the causes of cancer. This has been known for many, many years before we discovered a million of them. And let's just say it again, because this is the way it was explained to me 50 years ago, and it hasn't changed. You need two things to cause cancer. You need substances which cause the mutations, and then you need factors which multiply the cells. Because a mutagen may not be a promoter, or an initiator may not be a promoter, it's the same thing. And the factors which cause promotion, like normal hyperplastic processes, may not at all be carcinogens or initiators or mutagens. I like this. It's a pretty simple diagram, and I'm going to make it bigger again. And it's not anything really different from what we've already said, but it'll reinforce what we said. You have a carcinogen, okay, cigarette smoke, or the chemicals in it, it in itself could be detoxified, okay, and then excreted, or it could not be detoxified. And if it's not detoxified, it does its damage to the DNA. It causes its mutation. Now, that doesn't mean it's going to kill you, because remember, there's DNA repair mechanisms. And there are also mechanisms for apoptosis as well. But what happens if it's permanently promoted now? This is the concept of promotion. In the promotion, you have cell proliferation, you have differentiation, you have cells which look different, have different antigens, and now you have a pre-neoplastic clone which is promoted, and that's your cancer. So don't you think it would be logical, in fact, not only logical, but a fact, that the process of initiation even though it overlaps and needs the process of promotion, it basically occurs before the promotion process. Here's the usual suspects. I think I've showed you this pictures once or twice before. You say a crime has happened, so the police round up all the bad perps in the neighborhood and they put them in a lineup and they say, okay, who's the bad guy? Well, in terms of carcinogenesis, the same bad guys cause carcinogenesis as the same bad guys that cause inflammation, the same bad guys that cause the mutations of teratogenesis or birth defects. And if you want to make it simple, and believe me, you have to make it simple, let's just say there's three of them. There's chemicals, there's physical processes like radiation, and I'm not going to say trauma, but they're probably, well, let's not say trauma, but even though there's a little exception to that. There's chemicals, there's radiation, and there's infectious pathogens, mostly viruses. Look, there's one bacteria that is rampant. I don't know if you know it, but we're going to talk about it a lot soon. And in the chemical carcinogens, you now have the specific chemical initiators. Here are things from biochemistry. You may remember that the beta propiolactone might have a chemical bond that looks something like that. Okay, you remember DMSO, a very great solvent. The dimethyl sulfate looks like that. That's a bad carcinogen as well. Here is diepoxybutane, and if you're a real biochemistry jock, you could figure that out just from this diagram, diepoxybutane. Here is, and remember, chemotherapy, specifically certain types of chemotherapies, not only help in curing or regulating or controlling cancer, but they in themselves can be carcinogenic. Here, let me explain it to you, exact words that I learned 50 years ago from the world's greatest pathology professor, Martin Swerdlow. He said, that, verbatim, the very same drugs that cure or can cure cancer can also cause it. Okay, well, in many cases, these causes could be long-term, and they are being used short-term, hopefully, to prolong the life of the patient. Cyclophosphamide is at the top of the list, chlorambucil, nitrosoureas, but I think you can probably say that almost any type of chemotherapy, not immunotherapy, but chemotherapy, has the potential risk of causing cancer way down the line. Hopefully that patient will live long enough for it to be way down the line. Here's something called an acylating agent. These are all things that might be used in industry or chemistry, and the L-acetyl imidazole might look like that. The dimethyl carbamyl chloride looks like this. I'm not going to go into what they're used for. I've kind of lost track on that. Now, what about the common things? What about the so-called polycyclic aromatic hydrocarbons, the thing inside a tar? Believe it or not, here's a polycyclic because it has multiple benzene type rings in it. These things, the common thing, the number one carcinogen, the polycyclic hydrocarbons, like tars, okay? Believe it or not, they're not direct carcinogens, but they are pro-carcinogens, which means that they have to be metabolized or changed in the body to have a carcinogenic effect. Another thing, the so-called aromatic amines or the amides, the azo dyes, the substance present in the dye industry, these are also pro-carcinogens as well. Just to go over quickly, you may have heard of aflatoxin as being a cause of hepatomas or a big factor in hepatomas. You may have heard of the antifungal agent griseofulvin as being carcinogenic. These are also pro-carcinogens. They have to be changed metabolized by the body to be nasty. By themselves, they're not nasty. Here's a cycad, if you've never seen a cycad before. And the extract from this is called psychocin. That's also, and you all know that betel nuts, people that chew betel nuts get cancer in the oral cavity. And maybe I have a nice picture of some betel nuts for you. And there's regular old sassafras. Has something in it called safriol, or safrole, I'm sorry, which also is regarded as a pro-carcinogen. Oh, I'll throw out, that some of the heavy metals like nickel, cadmium, the insecticides, besides being other damages on your bone marrow, they're also can related to carcinogens or cancer as well. Some of the fungicides, the nitrosamines, the things that you get from the nitrite preservation of foods, amides we talked about as pro-carcinogens. Here's an interesting one called vinyl chloride. Did you ever hear of PVC, polyvinyl chloride? It's a substance that has replaced lead in pipes. So there was a factory in Kentucky where they made tons of that stuff. And they found out that a lot of their people that worked there were getting angiosarcomas. Why? Because the VC, or the vinyl chloride of polyvinyl chloride, is also a direct initiator carcinogen. The PCBs you may have heard of as being concerned of being in the atmospheres are things that were often seen in coolant fluids and electrical process and carbon heat transfer fluids. They are also indicted as being direct carcinogens as well. Not that you should know all this, but just be aware the stuff we talked about is high on the list of carcinogenic substances. They even say formalin is. It's not very high, but that's the one that the pathologists like to talk about because they breathe formalin fumes all day, their whole life. Okay, now what about the promoters? Well, aren't regular hormones, especially the steroid hormones, which go directly to the nucleus to cause that nucleus to multiply, that would be a promotion or a hyperplastic or a trophic effect without actually being a carcinogen. Other drugs can do that, cause hyperplasia of tissues. The phenols are also indicted as being promoters but not initiators in the malignant process. And here's something called the 4-bol esters and that activate kinase C, which also by itself is a promotion effect rather than a direct carcinogenic initiator effect. We all know radiation causes cancers. We all know radiation zaps your DNA, okay? We know that all three of the common cancers of the skin, the basal cell carcinoma, the squamous cell carcinoma, the malignant melanoma, they're all heavily influenced in their process by ultraviolet light. We know that ionizing radiation, whether or non-ionized radiation, whether they're photons, which is non-particulate, or particulate like beta particles, alpha particles. We know that these can also damage DNA to cause mutations. We know that most of the classical malignancies, and certainly the earliest seen malignancies after radiation exposure, like in Hiroshima, for example, were hematopoietic malignancies again, lymphomas, leukemias. The number one indicted malignancy following exposure or long-term exposure to radiation is acute myelogenous leukemia. Okay, the thyroid malignancies were also seen not long after the exposure either. In other words, 90% of them were seen like within 15 years of the exposure in the Hiroshima victims. Solid tumors also are susceptible, but certainly the leukemias and lymphomas are much more. It's not common to see basal cell carcinomas in areas where there's never any sun exposure. Why? It's because maybe that skin has been in contact with a therapeutic radiation field. I've seen that several times as well. A young person with multiple basal carcinomas in the part of the chest that's never exposed to sun Well, that person had radiation to the mediastinum. Same principle. Viruses, well, we know that HPV not only proliferates squamous epithelium in a benign fashion, kind of like a promoter effect, but also is the main cause of squamous cell carcinomas, particularly in the cervix. You could think of carcinoma of the cervix as being a sexually transmitted disease. Okay, EB virus, Epstein-Barr, the same old critter that causes mono, is highly indicted in Burkitt's lymphoma. Okay, HBV, hepatitis B virus, not only can it cause a cirrhosis of the liver, ultimately, okay, after a chronic hepatitis, probably the number one cause of post-hepatic cirrhosis, but the virus in itself contributes to the type of malignancy that you see in a cirrhotic liver called hepatoma. We know that HTLV1, the first generally studied retrovirus in humans, causes T cell, T lymphocytic malignancies. We know that HTLV3 wound up being the AIDS virus, but then we decided to rename it to just HIV. The Kaposi's sarcoma herpes virus, or human Kaposi's sarcoma virus, which causes a low-grade malignancy, works also to cause Kaposi's sarcoma, which, as you know, is very, very, very common in AIDS patients also. But you do not see the HIV virus here by itself. What basically you see with the variety of HIV malignancies is an erosion of the immune system which guards against those malignant proliferated cells. So let's go into the immune system. By the way, I think we're still transmitting. I just got a little pink thing that sometimes it says I may have audio problems, but I think my audio is okay. So can I just please ask somebody again, is my audio working properly? If you say yes, I'll be very happy. Good, good, good. How do tumor cells escape immune surveillance? We've been talking about oncogenes and oncoproteins. Some of these should not be recognized by MHC molecules, or some of them just might mutate. So they escape immune surveillance the same way bacteria and viruses do. They develop antigens which is not recognized. Or they just may have a decreased number of MHC molecules, which would normally be picked up by the MH2 molecules on the antigen-presenting cells, the macrophages. And remember, it's not just a antigen and antibody, that connects. We also have this concept of co-stimulation molecules, okay, like CD28, another one called ICOS. If these molecules are not present due to any reason, then the ability of the antibodies, to connect to antigens on the tumor cells may be impaired with. We know that immunosuppressive agents can also decrease that thing, okay? In other words, some types of chemotherapy. Sometimes you have a process which we see with bacteria and viruses called antigen masking. In other words, the antigen is there, and it would normally be recognized and destroyed, by the T cells. But what if they're masked for some reason and they can't be recognized? And finally, the one that's the scariest is that some of these tumor cells have mechanisms to destroy the T cells, specifically the CD8 cells, which are the cells which are the most important cells in the destruction of the tumor cells. So that's why, of all the potentially cancerous cells we have in our body now, which are normally surveyed, it is possible that all of us may have hundreds, thousands, millions of cancer cells in our body, but they're constantly being surveilled or destroyed, ultimately by the action of the direct killer, the CD8 T cell. But these are reasons why that may not happen. A tumor grows. It has anatomic encroachment on its neighbors. It could be a blood vessel. It could be a bone. It could be a lumen. It could be a spleen. It could be anything. Just think of any tissue occurring anywhere could have a pressure or a invasive encroachment or an invasion on any of its anatomic neighbors. The tumors can also produce hormones. They may not be exactly the same as the type of hormones we think of, like cortisol, for example, but they could be close enough to have a hormone type action. And now you may have an endocrine system because the tumor cell is producing the hormone rather than the endocrine gland. Tumors can bleed, they can rupture blood vessels, they can cause an infection by virtue of destroying the barriers which prevent infection. They could rupture blood vessels, causing an immediate death. They could infarct blood vessels, causing death of a major area or of an organ. And of course, they can metastasize. And the metastasis now itself can do all these things as well. This is pretty grisly, isn't it? How about if we look at the concept of cachexia? Why do people with malignancies often waste away? Okay, they waste away for several reasons. One, probably the biggest reason, is that tumor cells can cause excessive production of TNF. Remember, TNF, we said, was a growth factor. There's an alpha and a beta, but alpha was the first one that was described. So it was called TNF alpha. But before it was called TNF alpha, it was called cachexin. Why? Because we saw increased amounts of it in people with cancer. You remember, it's produced by macrophages. It's autocrine, but it also stimulates the macrophages to chew up even normal tissue all around it. Now, when a cachectic person loses weight, he loses both fat and muscle at about an equal rate. When a person goes on a diet, he theoretically loses fat more than muscle. So what's the difference between a person on a severe diet and a person that has a malignancy? Well, the person with the malignancy is probably destroying his non-fat just as much as he is his fat. Another cytokine, interleukin, especially interleukin 6, acts as a cachexia factor. And finally, another factor called PIF, very properly named because it stands for proteolysis inducing factor, and that's what it does. It accelerates or increases the lytic or breakdown action of proteins. See, not just fat. People that have malignancies may be diagnosed not because you diagnosed the malignancy, but you diagnosed other diseases which are related to the malignancy. Sometimes these associations are normal, you can understand it, and sometimes they're still mysterious. But if you have a person, for example, that has an increased production of a wide variety of hormones, which we're going to see on the next slide, those hormones could be being made by tumor cells, and they may not be the exact same chemical structure as the normal hormone, polypeptide or non-polypeptide, but they may also act like the so-called chemically normal compound. That's the biggest class of paraneoplastic syndromes. Some people with muscle wasting, nerve wasting, we talked about cachexia, may be indicative that there's underlying malignancy. We talked about an area of the skin that is hyperpigmented. That's why it's called nigricans. It's also called acanthosis nigricans because it's also has increased layer of epithelial cells. We've seen these with diabetic patients, but you can also see them with cancer patients. There are conditions in which you not only have inflammation of the overlying skin, but the underlying muscle, called dermatomyositis, which are highly linked to malignancies as well. There's a condition called HPOA, or hypertrophic pulmonary osteoarthropathy, in which you can see the joints are thickened with connective tissue, with cartilage, with bone, and that is often a sign that there may be underlying malignancy, especially a lung cancer. And if you see lung cancer patients, probably the first thing you're going to be taught in the clinics is take a look at their fingers and their knuckles to see if they're a little bit more prominent. You can have vascular problems like Trousseau syndrome, forming clots, migratory clots in various parts of the body, because some of the tumors can produce a glycoprotein, which accelerates the process of coagulation, even of the blood heart valve itself, and endocarditis. Just about every cancer patient that's advanced will have some type of anemia. There are so many mechanisms that would explain this. The easiest ones would be is that the bone marrow is being replaced by tumor, but that's just the tip of the iceberg. So many types of malignancies. You'll just notice almost all of your cancer patients that you'll have will probably have some type of edema, even though it may be normocytic and normochromic. Okay. Patients with the nephrotic syndrome, basically due to antigen antibody deposits in the renal glomerular basement membrane, may be indicative of a malignancy as well. Okay, I would go a step further. I would say any very, very elderly patient that comes in with some type of complaint which is unexplainable, the very, very first thing you're going to do is a workup for a possible malignancy. But let's talk about the single biggest type of paraneoplastic syndrome, the endocrine paraneoplastic syndromes. It's a big chart, but we don't have to memorize it. We just have to know the concept. If a tumor makes a substance which is like ACTH or ACTH-like, resembles it, then you're going to have a patient with Cushing's syndrome, not because there's a tumor of the pituitary or hyperplasia of the adrenal cortex, or because they're on too many steroid hormones, but because you have a tumor, maybe in the lung, maybe in the pancreas. Even neural tumors can produce an ACTH-like substance. What about somebody that comes in with inappropriate ADH? Well, maybe the tumor is making an anti-diuretic hormone, okay? Not the posterior pituitary, but ectopically in the tumor. What about patients with hypercalcemia? Well, do you think they have a parathyroid tumor? Well, maybe they have a tumor that produces parathyroid hormone. The most common one, probably statistically, is squamous cell, but breast cancer. I've seen it in renal, some of the leukemias and lymphomas. That's a big one, okay? They don't have hypercalcemia, okay, because of other reasons other than the fact that they may have a tumor that's producing a parathyroid hormone-like substance. What about somebody you might be considered to, you may be wondering why they're hypoglycemic. You think they have a tumor of the pancreas that's causing an excessive glucagon? Well, it may be a malignancy, like more likely a mesenchymal or mesenchyme or connective tissue malignancy, like fibrosarcoma, which is producing an insulin or insulin-like substance. And guess what? I just made a mistake. I realized I said glucagon, but excessive insulin is hypoglycemia. Okay. People that have tumors that might produce serotonin may have what they call the serotonin or carcinoid syndrome. Excessive carcinoid will result in two big clinical factors, flushing and diarrhea. That's the result of excessive serotonin, 5-hydroxyindolosinic acid. You can get carcinoids of the GI tract, probably the most common. You can get them of the lung as well. And it doesn't mean that they are producing too much serotonin in places other than the tumor itself. Finally, here's an interesting one. Let me ask you this. If erythropoietin is normally made by the kidneys. What if it's you have a tumor in the kidney of the cells which ultimately make the erythropoietin? Well, then you're going to probably have a polycythemia or excessive erythropoietin. This is the rationale behind the biggest category of paraneoplastic syndromes, which are the endocrine paraneoplastic syndromes. Finally, we're into the home stretch. We talked about this before. What is the difference between grading and staging of a tumor? Well, a pathologist thinks he's really cool and he's saving lives because he looks at tumors all day and he goes, well, this tumor is well differentiated, which means it's going to behave better than one which I see under the microscope as being poorly differentiated. And that's nice because that's true. If you study a tumor and you could say it's well differentiated, that is of amazing good benefit and good news to the patient's doctor and the patient. But even much more important than grading is the staging. It doesn't matter how damn well or poorly differentiated the tumor is. If it's spread widely anatomically throughout the body, it's going to be bad. So listen to this. A tumor with a high stage and a low grade is much worse than the tumor with a high grade and a low stage. It's not important as how the damn cells look, it's how they behave. That's another way of saying it. And this question, by the way, is just about in every step exam I've ever seen, and every pathology board exam as well. So here's a tumor of the skin. Here's normal skin hair up in the upper right. Here you see a tumor here that looks a lot like the normal skin. It has pearls. Here it doesn't look quite as much, but if you look carefully, you might see tiny little hairs in these little spaces between the cells. So you still know it's skin, but it's not as well differentiated as the pearls. Now here's a squamous cancer of the skin in which you don't see pearls, you don't see these little intercellular bridges. So you know the well one is going to be, it looks better and looks more like normal skin, so it's going to behave better. It's going to have a better survival than something that's poorly. You could attach various letters and numbers to this grading system as well. Pathologists love to do that. They change all the time. So here's something that is the most commonly type of grading system done. It happens to be in a glandular organ called the prostate. These are glands. These are prostate glands. So let me ask you a question. If I told you that that was a prostate adenocarcinoma, and that one was a prostate adenocarcinoma, and that one was a prostate adenocarcinoma, and that one was a prostate adenocarcinoma, I would ask you, hey, which one of these four looks the most like normal prostate? And which one looks the least like normal prostate? Well, you would probably say instantly the one here in the lower left, because it doesn't really form really circular glands. They're kind of like linear streaks. That's probably the worst one. So let's call that a poorly differentiated or a high grade. And if you wanted to say A, B, C, D, E, or 1, 2, 3, 4, 5, you could give it numbers or letters. But let's say if we wanted to go from 1 to 5, this would probably be about a 5. And this one would be a lower number, like maybe a 1 or a 2. And then here's something in between. Well, they've actually have developed, Dr. Donald Gleason is the hero. He's the person who originally developed the Gleason grading system for prostate. And basically said, if it looks like this, call it a 5. If it looks pretty normal, call it a 1 or a 2. And now you could give not only the main part of the prostate a number, but you could give a secondary part of the prostate tumor another number. So as you would guess, probably the Gleason system for grading, or the Gleason's final score, would anywhere be between a 2 and a 10. So if you got a 2, you're happy. If you got a 10, you're not happy. And because pathologists have so many differences of opinions, if somebody calls it a 7, Another really smart guy might call it a 6 or an 8. But anyway, this number is very, very important because it also determines the type of therapy they're going to get. You know how to diagnose cancer. We biopsy it. We can scrape off the cells in an exfoliative cytology, or we look at it under the microscope by sticking a needle into it, which is not only less invasive, but also usually just as accurate and saves money because it's usually the results in less hospital stay, or what they call LOS, or length of stay. And guess what? It saves the government money, so you know that this has really, really become popular now over the years. The single biggest advancement in the last, let's say, 20 or 30 years has been immunohistochemistry, because not only can we diagnose tumors or cells or anything just by looking at hematoxylin and eosin stains, which is what we basically see in the lab, but now we could stain the cells for antigens because we use antibodies which have colors labeled to them. So if we see a color on a tumor, we know it's a specific antigen. So let's say that you see a malignancy and it is so poorly differentiated, you don't even know whether it's a carcinoma or a sarcoma. So you get markers which are specific for connective tissue. You get markers which are specific for epithelial cell, and if they light up, it helps you a lot. It also is important in the classification of hematologic malignancies, whether certain of the cells, the lymphocytes, the lymphomas, the leukemias, have certain markers. Not only does it help you classify it better, but it helps you with better therapy as well. Sometimes you'll see an adenocarcinoma, let's say in the lung, and you go, wow, I diagnosed adenocarcinoma in the lung. Yeah, well, did it start there or did it come from somewhere else? You say, well, I don't know. So you get antigens on that tumor which are specific for prostate, or they're specific for breast, or they're fairly specific for colon. And you can say, not only do I see adenocarcinoma in this lung, but I can tell you it's metastatic, and I can also tell you where it probably came from as well. Finally, you can look at parts of the cell with receptors to see whether the tumor is going to respond to estrogen therapy or progesterone therapy. And that's very, very good for guiding prognosis and therapy as well. Tumor markers, okay. Not some of the tumor cells, as you know, make substances which identify it, but can also circulate in the blood. So, for example, here's a bunch of different types of malignancies, like let's say prostate malignancy might produce prostatic acid phosphatase, which is not only can you stain in the cell, but it might circulate. Or more likely, the newer, better one called PSA, which they call prostate-specific antigen. But remember, it's prostate-specific antigen. It's not prostate cancer-specific antigen. So if you have a big, big, big amount of PSA in your blood, it don't mean you have prostate cancer. It means that you may just have a normal prostate the size of an orange, okay, rather than a walnut. Some of the glycoproteins are produced by tumors, like CA125 is a good marker to look at the tumor load of ovarian cancer, okay? So if you have done therapy with the colon or the ovary or the prostate, and all of a sudden some of these markers occur again in high amounts in the blood, you might say there's a recurrence. So they're much more important for looking at recurrence of a tumor that's already been treated. And that's also true with hormones and some of the markers that you see with certain malignancies, like alpha-fetoprotein with liver cancer. But remember, the same substances which you can measure in the blood are also present in the cells, which helps you diagnose perhaps what type of malignancy it is. Got the last slide now, and guess what? It's not even 2 hours yet. I thank you for lasting the full 2 hours, and this is just something I think may have showed you before, but You know, I can't tell you the number of times people have come up to me and say, hey, well, maybe you guys won't need microscopes anymore because now you'll just look at all the different genes on a slide, on an array, and you can tell from the pattern of genes what it is or whether kind of tumor it is, what's the best therapy for the tumor. So yeah, cells have fingerprints of genes. Some of these genes may be normal. If it's pink or red or green or blue, it may be mutated. So in the old days, we just looked at hematoxylin and